Vascular for inviting me, and of course the previous speakers because they've kind of set this up pretty well. My talk is actually going to be much more nuts and bolts, just a little bit of data driven, but it really gets into the technical aspects of CRT. And I got into this for a different reason, but we'll get into that in a moment. Let me get into this. So first, my disclosures. I do have financial interests with Baxter and Fresenius. I'm on their advisory boards and speaker, but they're non-commercial. It's medical. All the machines out there are really good. I'll let the commercial people sell them. I'm not good at selling them. But I do want to help use them adequately, which is a big problem. And non-financial conflicts, I have none. So why are we talking about this? So I actually use this to describe the process to my patients, because this is you. We are bags of fluid. If you look at that right there, that's the heart, that's the lung, the liver. That tiny speck there is a brain. No, they're all functioning very nicely. Oh, muscles, tissues are all the plants, and all of this is very happy thanks to being bathed by this pristine internal milieu. And this internal milieu is kept pristine by this remarkable organ called the kidney, or the filter. Now, what happens when it starts to fail? That's what happens. The internal milieu gets all muddy, all the fish start to get sick, the tissues too, the brain has disappeared, and we simply cannot function. So what is the goal of renal replacement therapy? It's to try to restore this pristine internal milieu so that the body can function more normally. I know this isn't completely correct, but it's a good analogy for it. Now, how have we normally done this? Well, for many years, all we had was intermittent renal replacement therapy, which was quite good and has its role, but it doesn't do what the kidney normally does. The kidney normally works 24 hours a day, 7 days a week to maintain this. And so CRT for our sickest patients was developed to overcome some of those shortcomings. Now, I refuse to include the next slide because, you know, when we look at this, CRT should be much better. It should be easy to prove. Again, I would highlight what Stu said. It's a complementary therapy. I always tell my fellows, give me your goal of therapy. And then we're going to try to achieve that goal. We're going to choose a modality based on what best achieves that goal, right? But when you look at it, you know, it's been hard to show improvements in hard outcomes, which isn't all that surprising, honestly, in an ICU setting. And there's numerous reasons for that. But the one that we have to address is how well are we providing the renal replacement therapy, or CRT? You know, Stu showed some data showing we weren't really providing intermittent renal replacement therapy that well. That's what some of the studies said. And there's a lot of data out there showing that we haven't done this either. Now, I refuse to show this slide. It's not included because it's actually data from us in 2003 that was published by a different group later. Our data was published, and HR makes me reference that group. I'm not going to give credit to anybody for stealing data. But what we did was we looked at our own internal data because the administrators came and said, this is too expensive. You guys have to show us something here. And we were like, we know what we're doing. Everything's fine. But then we started to measure our data. And it turned out we sucked. It was bad. Our average filter life was just under 13 hours. It would take us up to 8 hours to restart machines because our protocols for restarting were really bad. We had 9 changes in our prescription per day. You want to burn out nurses? Yeah. So, and our protocols were really cumbersome. So we had to go back and look at this. And, you know, well, this is one center. And I'll say the center was Mayo Clinic, so it's a good center. But until we looked at our own data, we really didn't know how bad we were. Well, this has been reproduced in a lot of the literature out there. This was actually published a year before we looked at ours, showing that we are only delivering 2/3 of what we are prescribing. This was shown in a trial, in a clinical trial, the Do-Re-Mi trial, that they were not delivering what they were prescribing. And this was later by a different group. And, you know, a lot of this was due to treatment interruptions. I was actually asked, well, who cares if you know, just turn up the dose, which is what they did in these other trials. They turned up the dose to make sure we delivered what minimum, right? But that's not a good answer because treatment interruptions have their problems too. I was actually asked this, well, we'll just change the filter over. This was asked of me 6 months ago by a division head. But there are other problems. It's not only the decreased dose of clearance delivered, but we lose blood products. There's altered medication dosing because your clearances aren't consistent. Fluid removal is inconsistent. So then I'm going faster to catch up. And we know that may be bad in certain situations. We still have to get the final outcomes of that. There's more setup manipulations. And whenever you have more setup manipulations, there's an increased risk of infection and of errors. We don't want humans touching these very much. And of course, the increased burden and costs that come with all of this and burnout. So we looked at this very carefully and we did a quality improvement and we did citrate, we did all these different things. And we found that we could group the reasons for circuit life shortening into 4 major groups. One was altered blood flow mechanics, which are circuit-related factors and vascular access. The second is ineffective anticoagulation. The third is increased treatment-related viscosity, and finally, patient-related factors. So we looked at this and did all of these, but it turned out that vascular access was the bottleneck. Until we fixed the vascular access, the others, they worked some, but we didn't really get the maximum benefit. This was so important that actually we got complete control of the accesses in basically 2 of the 3 last places I've worked. So that's what we're going to concentrate on. Now, whenever I bring this up, the eyes start to roll back. Come on, it's just a freaking access, right? And it just has very simple roles. It has to provide adequate blood flow. That is, it has to give you low resistance. It has to have a low complication rate and a long lifespan. But it turns out, without this, we're not able to perform great therapy. I like to mimic this to a great machine. This is a very nice car, like our CRRT machines. But, you know, you can have a great machine. But if you put bicycle tires on it, even pretty ones such as this one, it's just not going to perform. And this is what happens when we're not giving adequate vascular access. Now, most people will say, we don't have too much of a problem. Well, the data doesn't really support that. The data supports that we do have a problem. I'm not going to go into the details of that, but you know, you always go to a place and the physicians, who we go in and there for a few minutes and we're all, no, we don't have a problem, whereas the nurses are sitting there going, you know, because they're the ones who are struggling with it, and that's the truth. Now, you look at this, and both of these are from my centers, by the way. This is how many access return alarms we had, and this is why I didn't think I had a problem. And I had very low levels of return alarms in this first scenario, about 3%. So how could the access be a problem? But remember, this is a citrate protocol, so my blood flow rates are low, so I'm not going to generate a lot of alarms. This other one is a non-citrate protocol where I'm using very high blood flow rates, and guess what? 64% of my alarms were access related. So I had poor access. I was just hiding it when I was using the low blood flow rates. And I can't get away from one thing, because that's, you know, 1, 2, 3 centers. But no matter what I say, I'm still not delivering, and I have to look at that. And access has turned out to be a huge thing. Now, the reason people don't think they have an access problem is because they're confusing catheter failure with catheter dysfunction. Catheter failure is easy to diagnose. Basically, the CRT cannot run in a continuous way. You're going to have non-sustainable blood flow. It triggers alarms, normally high arterial access pressures or high venous access pressures, right? But that's a minority. That's easy to figure out. That's just complete failure. What happens is that we tend to have a catheter dysfunction quite a bit more. And this is very difficult to find because the CRT does run. It's just, it doesn't trigger alarms. but it promotes circuit failure. This is those circuits that are going down very frequently. Not all of them. There's other reasons, but this is a key one. And I get inadequate clearance. Remember, clearance, not dose. These are different concepts that I won't be able to get into. Now note, these definitions are for CRT and for CRRT. They are different, a little bit different than what we see in intermittent. And the causes are the same, it's just different severity. It's clotted, pink, and malpositioned. Now, how do we look at this? Well, to understand this, you have to understand what blood flow is in the catheter. When you set the machine at a certain blood flow, you think you're giving that blood flow, but that's a calculated number. Okay, it's not a measured number. I am only aware of 2 people who have actual flow probes that can measure flow. Ian Baldwin in Australia and my group. And we're going under certain assumptions, which we're assuming Poiseuille's law, which applies to fully developed laminar flow of a Newtonian fluid in a straight rigid tube that is longer than wide. And so we have violated every single one of those assumptions except for longer than wide. So under normal circumstances, it's actually quite close. With a well-functioning catheter where you're measuring flow, you're around 10% of difference normally, okay? But if you don't have a good catheter, even though you're not triggering alarms, your flow can alter. We've seen over 30%, for example, in a misplaced left IJ or femoral in an obese person. So you can have big variations in that. Now, this does tell you shorter, wider catheters are best, and we'll touch on that, but there's other factors that are present. And those are the ones that we're going to touch on. So people ask me, well, how is blood flow different? Well, blood flow is going to go, you basically have a peristaltic pump that's pushing blood forward, but not all goes forward. Some can go backwards if I have a high negative pressure or I have a high positive pressure on the post-pump area. And those aren't absolute values. It's a ratio between the two. That's why I can't give you one number and say, oh, this is a problem. No, it's that ratio. And that's why it's different for different settings. The other thing is that this refill is different. This is an active. Think of the heart that's a suction pump, right? Well, that's the same thing for this segment of the tubing. It needs elasticity. It needs to open up to help suck in blood, and then it gets compressed and presses out. Well, as that loses compliance and it starts not being as flexible, you're going to decrease filling as well, and that's going to affect your pressure as well. Now, this was measured by Ian Baldwin. I mentioned that he has a flow probe for this, and you can see at the beginning of therapy, he was doing just fine. Then they rotated the patient. They had some problems, and we don't know what happened to the catheter tip or anything, but he started to have bigger periods of flow reduction. And remember, these are pulsatile flows because it's a peristaltic pump. That's why you get pulsatile flows. And he had all these periods of flow reduction, and this led to catheter failure. And he's actually published a series on this, which is very provocative. So that made us look at what are the things that can affect catheter flow. I put in some slides that are for your perusal, but I'm not going to go over them in detail here, but they are available for you. So you don't even have to take pictures. We give them to life. But anyways, the polyurethanes were basically developed for our short-term catheters because of ease of placement. They're stiff, but they soften up when they reach body temperature. So they're quite soft at that level and not very traumatic, whereas the silicone-based are used mainly for our tunneled catheters. They both have advantages and disadvantages to them. And again, I'll just leave that for your review later. But the other characteristic is what the shape of the catheter is. In theory, based off of Poiseuille's, straight would be better. But as everybody knows, straight up in the neck oftentimes is never straight because things are curving around and you're moving it and everything. And so that's problematic. These curved extensions were meant to help with that in a way, but you have to be careful because they can kink up in these curves right there. And again, I'm introducing another curve, which I'm losing my laminar flow during, and so it's a problem. This, I do lose some of the laminar flow because of the pre-curve, but because it's a rigid catheter, you don't have deformation of it. And this has been proposed to be better The problem is that the study that proposed it to be better was actually looking at inpatients that transitioned to outpatient, and they actually have it in for a long time. They had less infection rates that was mainly generated in the male. It's hypothesized because of the beard and all, but we don't, that hasn't been reproduced and we don't know. At this point, I would say do your internal checks, and based off your internal data, you're going to have to see that. And you're going to see that. I'm going to say that for quite a few things because we just don't have good data. And there's so many variabilities that are institution dependent that you have to be very careful when you're saying these things. So the other thing is what kind of characteristics. There are different types of catheters. The two that are most commonly used now are the double D or a triple lumen and the high flow or circle C design. And again, we don't have good data to show which one's better. I would use your internals. We tend to use high flow. I don't like triple lumen just because I'm taking away real estate with that third lumen. Plus, people are now intervening, on that third lumen, changing things over, and that can be problematic both for function and infection. The tips, there's different types of tips. Once again, you'll see a lot of data, small studies, mainly looking at short-term outcomes that the manufacturer will claim theirs is better. There's no hard data on any of this. You can use whichever one you find more useful. In our hands, we use like the shotgun tip, but they do have to be placed carefully. But again, I'm not recommending it. I'm saying look at your own data for that. Now the side, this is why I don't like the triple lumen. There's two reasons. One, the manipulation, but also I'm taking away real estate. The most important determinant of flow, of resistance, is your diameter of the catheter. And so I'm taking away diameter of the catheter by putting in that third lumen. I prefer to have all of that real estate available for dialysis and not for anything else. Remember, the flow that you're needing from a different line, if you're going at 240 mLs per minute, and I did that because of the math, well, divide that by 60, that's 4 mLs per, 240 mLs per hour is 4 mLs per minute. Whereas with my dialysis catheter, I'm going in at 100, 200, 300, even 400 mLs per minute. That's why I need my real estate, not off that other one. Length does make a difference as well. So shorter would be better, but not too short, which I'll show you in a while. And where should I be placing it? I mean, the two things that we found that really matter for dialysis function is one, the size, and two, the tip location. Remember, we're going at very high flow rates. I need to be in a very high flow vein. So it's pretty widely known that we really should be in the SVC, but it should be down at the cable atrial junction. It shouldn't be high in the SVC because everybody has a different length of SVC and you don't know what the flow is there. So you really want it close to the RA. The tip should be greater than, more than 4 centimeters away from below within the right atrium, which normally converts into 3 centimeters below the tracheobronchial angle, the right tracheobronchial angle, or 5 centimeters from the carinae. And the tip must be parallel. So it really should be, right there. You're going to see tips higher up. They're very unpredictable, and I'll show you that. The femoral catheter actually, ideally, from a flow standpoint, should also be close up to the RA, except that the length is so long now that now the length becomes important. And in reality, the flow in the IVC is so great that just having it in the IVC, even low down, is enough. So you don't have to go. And so normally we use 24 centimeters. So this is an example of where the tip should be. My intensivist, I'm an intensivist as well, but one of my colleagues said, no, that's too deep. You're going to have trouble with that. We're going to have complications. No, that's not correct. That's actually where it should be. And one more thing to take into account. It has to be that low because you have a functional tip. It's not just the tip of the catheter. Remember, the tip of the catheter is returning blood. The top end of the catheter, 2 centimeters, 3 centimeters above, is where the suction of the blood's occurring, and that has to be away from the walls. That's why you need it down. If you're closer up, veins are coming in and out, your flow changes very quickly along the SVC. That's why you need it down, to make sure that you're functional tip is in that high flow region, not just the tip. So we're going to do a case to go over these recommendations overall. This is a real case. It's a 53-year-old female, past medical history of hypertension, obesity, diabetes, and CKD, has refractory septic shock and oliguric AKI. Now she's 5'8" and weighs 140 kilos. Yes, we have to know this when we're going to put a catheter in. So we decide to start CRT, and they're going to place a catheter. So the questions that I have to ask myself, general questions, and these were asked by KDIGO, much to their credit, although I'm going to criticize them here in a moment. Here are the considerations we have to have. First, what type of catheter would you choose? Tunneled versus non-tunneled. What site and length would you choose? What are the recommended placement strategies? How do you confirm catheter placement, and how do you maintain a catheter infection-free and flowing well? Well, these are the recommendations. Use a non-tunneled temporary hemodialysis catheter, their recommendations or suggestions. Preferred sites are the right IJ, the femoral, and the left IJ, and those, we'll go over these in more detail in a minute. We use chlorhexidine maximum barrier precautions and ultrasound-guided placement for placement of the catheter. We confirm placement by chest X-ray, and we don't use topical antibiotics or antibiotic blocks to prevent catheter-related infections. We're going to concentrate on these three, but I'm happy to take questions on the others. So what type of catheter would you use for this patient? A short-term hemodialysis catheter, that means a non-tunnel catheter, a tunnel dialysis catheter, or a power pick. And yes, I included power pick because I've been asked to dialyze patients through a power pick. So KDIGO. So here's a caveat on KDIGO. Don't get me wrong, I'm not trying to trash them. These are excellent scientists and everything, but things change and data changes, and sometimes the expertise is different. Guidelines are your foundation, but they're not written in stone. There's an old saying, in God I trust, all others bring data. We need to bring data, we need to update things. Catheters, like I said, most people roll their eyes when I talk about catheters, and so it's not something that catches a lot of attention. And so it wasn't looked at quite as thoroughly as it could have. They did recommend starting with a non-tunnel dialysis catheter rather than a tunnel catheter. They did give it grade 2D evidence, meaning expert opinion mainly, because there is very little data on this overall. Now, I always get pushed into this, but you have to look at the quality of the data too. People have recommended tunnel dialysis catheters because my cardiovascular surgeons want tunnel dialysis catheters because they say infection rates are less. But remember, we're extrapolating from an outpatient setting to an inpatient setting. And the data has not been nearly as consistent in the inpatient setting with infection rates, especially in ICU patients. It's a paucity of data, to be quite honest, because the data's out there is very low in number. And of course, because of the complicated procedure to put in a tunnel catheter, the delays and everything, we don't. So I agree with this one quite a bit. Now, this was challenged by a great group. Sus Waker is a friend of mine, and he did the best study that he could. It's a prospective cohort, but it's not randomized. And what they did is they compared characteristics of RRT, both intermittent and CRT, in acutely ill patients in the hospital, depending on the catheter they had. Now, let's just ignore the intermittent dialysis part, and let's just pay attention to the CVVH part. Now, the first thing to look at is blood flow. Now, this is a calculated blood flow. Well, it was set at, not the measured blood flow. And as you expect, program basically sets it all the same, about 250 in their program. And so that's what's there, and it's not different. That actually is a problem in a way, because the short-term catheters and non-tunnel catheters are different size and length to the long-term, so we're not really comparing apples to apples. And blood flows, if you actually measure them, are going to be different in those. This is actually, I don't know what to make of this next group. I've kind of, the pressures, they're actually backwards at what you would expect. This is an error in there's no way that a larger catheter can have a much higher pressure at the same blood flow, right? But physically it's impossible. So either there's a problem with it or just the data was transcribed, but it doesn't really matter because that doesn't come to this. pressures like this don't really mean very much unless they're extreme. It's the trend in pressure that means something, because it's going to be different depending on what your settings are and what the patient characteristics are. But again, let's go down to the next group, which is rate of interruptions per catheter. And this is important. So their normal group, the TDC, they normalize for this, has a number of 1, empiric, right? Because that's the group that had the less interventions, whereas the short term had almost 3-fold higher. That means the nurse is intervening 3 times higher, more times. That would argue for a tunneled catheter being better. And in fact, they concluded that compared to non-tunnel catheters, the tunnel catheters had improved RRT delivery and fewer mechanical complications. And it should be considered when not clinically contraindicated, giving the potential for improved delivery of RRT as well as outcomes. And again, Suss is a great guy and all, that's too strong of a conclusion. Their data didn't show it. And in fact, if you look at it, if you look at hours on CVVH, it's the same between the 2 groups. And if you look at the BUNs, which is what they reported, it's the same between the groups. So they didn't really show improved delivery. Okay, they showed less interventions, which is still important. Nurse burnout's a big thing, especially nowadays. But we need to look at it. And it's also not comparing apples to apples. We really need to look at this more, because if you look, it might have been the type of catheter, but it might have also been just the position of the catheter tip. 87% of the non-tunnel dialysis catheters were in the SVC. Only 13% were in the right atrium. Whereas with the tunnel dialysis catheters, it was the opposite, right? You can also kind of predict that a lot of these catheters are going to be short because they use 15 centimeters and below. And I'm going to show you why that's too short later in the non-tunnel group, whereas in the tunnel group, they had longer catheters. So this is a different study, and actually they showed a couple of things with this. One is they looked at longer length catheters versus shorter length catheters, and they found that the longer length catheters tended to be in the right atrium much more than the superior vena cava, whereas the shorter catheters tended to be in the SVC, as expected, right? The primary outcome was those that were in the right atrium had a 7-hour, 25% longer filter life. You could argue this is an optimal filter life anyways. Yes, I would argue that. But you still have a pretty significant difference between them. And most importantly, because everybody says going into the right atrium is going to cause all these complications, right? Again, that's taken from old data when our catheters look like Ferrari spheres and not the modern catheter polyurethanes that we have now. There was no difference in arrhythmias or any complications between the 2 catheter groups. Now, I'm not proposing that you go and bury the catheter down in the tricuspid, right? High up. Our goal is to have it at the cavolateral junction plus minus 1 centimeter. And the reason we say plus minus 1 centimeter is because you'll get plus minus 3. If you say plus minus 3, you're going to get plus minus 7, right? So that's why we do it this way. And this is just a result of catheter life that showed that it was improved in those longer catheters. Okay, so I took away the answer for a couple of questions there. One, tunneled versus non-tunneled. I prefer non-tunneled because I can place them quickly. I'm not convinced by the data of not tunneled being better yet. But we're going to have to, it does open up some questions. Suss's data does open up some questions that we need to check and look into. So that might change in the future. Also, of course, the procedure for placing a tunnel has to become easier for that ever to become widespread. The other question was where the length of catheter should be. Well, we're going to get to that in a moment, but to do that, I have to know where I'm going to place the site. So in this patient that we presented, what insertion site would I choose? The right or left subclavian, the right or left IJs, or the femorals? Now here's where I have my first difference in opinion with KDIGO, and it is based off of good data, by the way. But the question is whether the data is applicable to my patient population. They say we should go in the right jugular vein first, femoral vein second, left jugular third, subclavian with preference for the dominant site fourth. And they base it off of these 3 trials, Cathedia trials, which were European trials. that were pretty well done, but there's a few problems with them from our standpoint, and I'm not going to go over them, but they basically looked at infection rates, catheter dysfunction, and this is re-establishing. So when somebody had a catheter changed and they put a new catheter in, they looked at the secondary catheter and how that performed depending on the location. And they found their main findings were overall femoral is the same as the right jugular with regards to infection and function. But they have a couple of things. First, if they broke it down, and this should be BMI of 28, by the way, they broke it down into tertiles. The lower tertiles, below 28, the femoral performed the same as the IJ, the right IJ. But above 28, the femoral didn't do as well. So I don't know about where you work, but I work in the south of the United States. And getting back to what Javier said, one of our, metrics is that when we get a BMI less than 35, it triggers a malnutrition workup. So our average weight is 100 kilos. The average weight in this population was in the 70s, if I remember correctly, less than 78, I think. The second caveat is that not much information is given about the catheter length and where the tip is, and that's key. And I think that's the reason that their left IJs perform so poorly. This is, I have to, because Stu's in the audience, I had to put in a pediatric slide, and he can correct. And then he can correct me because he's the expert, not me. But this has been looked at in children as well. And the IJ performs better than the femoral in children as well. Now, we looked at this and said, the catheter trials are good trials, don't get me wrong, but they don't apply to my patient population. Again, our patient population, average weight, about 100 kilos. Tall. And placement is different. So we really looked at this carefully, and we came up with a different algorithm. And our first choice is the right IJ. Our second choice is the right IJ, and our third choice is the right IJ. Only then do we go to the left IJ and then the femoral. Again, in part because our patient population is large, but I also think it has to do with catheter tip placement. And I'm going to show you that difference next because that's key. It was so important for us that this is how we got approval from administration that we took over all catheter care. So the only patients who really don't get a right IJ placed are those who have no right IJ, or those, for example, heart transplant patients who are going to need that access for all the biopsies and everything. Other than that, if they have a triple line in place, we put another triple lumen in. This one gets flipped over to a hemodialysis catheter. There is no, our right IJ is much better than the left IJ. But now I'm going to do the right IJ, but that's not enough. I need to know where the catheter tip is. I want it deep down. So what length catheter should I use to get it down? Well, in this case, you can choose between 12 to 13.5, 15, 19, 20, or 24. KDIGO says that if it's in the right, it should be 12 to 15. The left IJ is 15 to 20 and femoral 19 to 24. These recommendations are based on the following references. Two are recirculation studies, chronic population, and one is a review. No actual data. And we don't have performance data, but we have anatomical data that's published both by Sipiak's group and Eslami's group back in the 90s. And what they use Perez formulas to calculate where the tip of the catheter was going to be. So the right IJ, if you're going to access the right IJ, you take the height in centimeters and divide it by 10. And 90% of the time, you're going to be at the cavo-lateral junction region. So what is that? Think of that. Height divided by 10. So the height is in centimeters. So 1 foot is about 30 centimeters, very close. So a 5-foot person is going to be 150. So a 15 centimeter catheter is good for somebody who's 5 foot. Most of my patients are not 5 foot. They're taller than that, right? So I need a longer catheter to reach it. And this data was before universal placement by ultrasound. So we've kind of gone higher and higher. So now we're looping over the ear to place these. So actually, if anything, it should be longer. If you're in the left IJ, you have to add 4 centimeters, subclavian -2, left subclavian +2. This catheter looks okay, didn't work at all. We solved it by dropping it down to this level. Okay, I'm not going to touch on these. I put it down just for your perusal. This is standard. This is standard not only for central lines, but for hemodialysis catheters. There are 7 studies showing that this reduces infection and outcomes. So the final thing I'll touch on is we recommend obtaining a chest X-ray promptly after placement and before the first use. A lot of times I'm questioned about this. It serves several purposes. One, it can help me know when I have a catheter that's slow. This catheter, I might give it a try, but I'm going to be quick to change it out if it's not long enough. It can help me when I have something abnormal. This one was actually pulled back by manipulation during other issues that were going on. It's quite short, and that's a dangerous catheter, not only because you might spill blood out, but because you're causing venous shear and you're going to have stenosis and things like that. One of the things that so many people are afraid of with the left IJ. I'm not, because I use a left IJ so infrequently. We use the right IJ. And this other one is just a bit long. The tip's down here. And so, we used it for measuring renal vein renins and to get a portal pressure. In reality, this one isn't that. This is a temporary catheter, but sometimes the surgeons will put in, or IR will put in a catheter down that way because you have central stenosis up. And so in order to achieve maximal flow, you'll do that. But they should really let you know. Sorry about the quality of these x-rays. Here we were testing the hypothesis that CRRT was an effective deodorant. This is the other side. This one looped back. So you're always finding these surprises out there. This is an intraarterial, 2 different intraarterial punctures that can occur. This one was a tunnel catheter that migrated, and it looks like it's just not making the curve, but on the lateral, you see that it's in the acetatus. And so no wonder why it wasn't functioning. The acetatus is not a vein that has very high flow rates. And this is the final thing, is that you have a triple lumen here. That tip is right there, and you have a catheter right there. Here, the same things occurring. And this is important. First, the central line has no business being that deep. You don't need it that deep. You're going at very slow rates. And second, when you're that close, I may be sucking up all the drug that I'm trying to infuse. And so, one of the factors of clearance is volume of distribution. It's protein binding, solubility, and volume of distribution, which are related. And I'm eliminating volume of distribution. So you can see this. We frequently see it with calcium infusions that are going up and up and up in citrate. And it's because we're sucking all the calcium straight out, essentially. So you do have to do that, check the chest x-ray. I can't get away from it really unless I have a specialized catheter. And I'm not aware of any specialized hemodialysis catheters with EKG or anything. But anyways, so what are the traits that predict optimal access function? First, ensure a clean, skilled insertion. Use larger diameter catheters. I don't like triple lumens because they decrease the diameter and because they increase manipulations. Our internal data does show that the double lumens perform better. The right IJ, left IJ, and femoral, it should be followed in that order, but it is institution specific. Look at your characteristics. This is important that you follow your own data, measure it, otherwise you don't know. Tips should be at or close to the RA in the cable-atrial junction, using Paris formulas to see which ones you need. Do not reduce the lumen with smaller gauge connectors. We consider using the side-by-side, which I don't even think are available anymore because are just our internal data, but that's just a mild suggestion. Again, you have to look at your own data. And the patient needs to be quiet, and you have to look at patient characteristics. Sorry about that confusion at the end. So thank you.